Well, good afternoon. It's really great to be here in New York at the VEITH meeting once again this year. My name's Anthony Comerota, and I'm a vascular surgeon from Nova Heart and Vascular in Virginia. I have the pleasure of being with three colleagues, Mike Lichtenberg from the clinic in Arnsberg, Germany, Dr. Mark Garcia, who's interventional and vascular consultants from St. Francis Hospital in Wilmington, Delaware, and my friend Mahmood Razavi from the St. Joseph Heart and Vascular Institute in Orange County. And we're going to talk about a growing problem, which is acute deep venous thrombosis and chronic post-thrombotic occlusion and its management. So there's increasing interest in getting rid of the clot. So let me ask Dr. Razavi, is there any reason why we should get rid of the clot for patients who have acute DVT?
Of course. The classic pathophysiology of venous hypertension being outflow obstruction, which clot does, and valvular reflux, which again clot would be a contributing factor to, would suggest that if we remove the clot in a timely fashion, that we could probably preserve venous function, valvular function, and get rid of the outflow obstruction. So therefore, it would make sense to do that to prevent post-thrombotic syndrome. Of course, there are other factors involved for the development of post-thrombotic syndrome, but venous hypertension is a major contributing factor. So it does make sense.
So it's to prevent post-thrombotic syndrome.
Absolutely.
Mark, are there any patients that are particularly high risk of developing post-thrombotic syndrome?
Yeah, well, we know that the patients who have central venous occlusion typically have worse venous hypertension and higher risk for PTS. Particularly those that have an obstruction with reflux are the highest group. But the other population that I think sometimes gets overlooked are those with obstructive DVT in the popliteal region. Those patients can be severely affected below the knee and have calf post-thrombotic syndrome, which can be quite devastating. So, but those are the major groups that I see particularly involved.
So, to quote Dr. Razavi's comment a couple minutes ago, anytime you have a thrombosed vein that receives the confluence of veins, like the popliteal, like the common femoral and external iliac, those are very high-risk patients for post-thrombotic syndrome. So, Dr. Lichtenberg, we have used the traditional method of catheter-based therapy has been infusion of plasminogen activators. And we've had success with that. Is there any downside? Is there any room for improvement as we move forward?
Yes, I think so. I would absolutely agree with what the colleagues told about the obstruction central. It makes sense to remove the clot, to remove the obstruction outflow problem. The question is, how can we perform this much more safer? CTT therapy is the established therapy so far. We have very good data for that. But I think it's fair to argue with more safer and more effectiveness therapy. And one of these are pharmacomechanical thrombectomy, mechanical thrombectomy, and I believe that we can move forward the story and take out the CDT therapy to pure mechanical thrombectomy. Then we are on a very much more safer side and prevent bleeding complications.
So the field has then evolved from we didn't even bring up systemic lytic therapy, but I think we'd all agree that's of historic value only. Is that right?
That's absolutely right.
So from catheter-directed thrombolysis to now adding mechanical methods to improve safety and reduce the duration of therapy. So, Dr. Razavi, what are a couple of the mechanical methods that have caught your eye as moving the field forward?
There are several very exciting technologies that are either recently entered the market or around the corner. All have to do with the efficiency of clot removal. in a timely fashion so we can treat iliofemoral thrombosis, long clot segments, large volumes of clot in a single session, which we haven't had the luxury to do so until recently. In our practice, we use a particular catheter called the Jedi catheter, which happens to have a pretty good efficacy. Some data behind it is coming out. Zalante, the old catheter that has been available in US for a while.
So that's the Angiojet?
Angiojet, the 8 French Angiojet. There are several others that are coming out with very creative designs in terms of capturing clot, encapsulating and removing them. Right now, the one that again that has caught my attention in our lab it has been the Jedi catheter.
So can you infuse a plasminogen activator with the fluid that you're using?
Yes, it can be done. It depends on the design of the catheter. This particular catheter, yes, you could do that, but you can do it with other catheters also. Mark has done a recent study in chronic post-thrombotic occlusions using a combination of drug
and we're going to talk about
and that's
the
exciting.
access data.
Absolutely. And so, but right now, as far as acute clot is concerned, you do. And my guess is that the combination treatments would probably be a wise thing to do unless the patient has contraindications to lead agents.
And Michael, in Europe, what are the mechanical methods in Europe that are gaining traction?
So it's also the Jedi system, which seems to have a very good efficiency in removing the clots. We are using a lot of pure mechanical thrombectomy devices like the Esprex catheter. This is a pure mechanical thrombectomy device using the Archimedes principle with a catheter 10 French large, which you can use to remove the clots. We did just finish a study on that with 56 patients. We did not need any kind of additional lytic therapy for the patient. We just
just did mechanical.
Pure mechanical approach. But what we did is that we, after thrombus removal, searched for an underlying reason. We did IVUS analysis on these patients to see if there's a May-Thurner syndrome or any other kind of compression syndromes, probably the reason for the iliofemoral DVT. So in conjunction with an IVUS-guided stenting therapy, we had an 86 primary patency rate in these iliofemoral 56 patients.
And once you remove the large volume of thrombus, anticoagulation becomes very important.
Absolutely.
Do you have any set protocol on how you anticoagulate these patients?
Yeah, we follow the international guidelines for DVT. So iliofemoral DVT means that you need at least 6 to 12 months anticoagulation. Of course, if you have a second or third DVT, then lifelong anticoagulation. But we did not set up an own protocol. We follow these international guidelines on conservative treatment for DVT.
Garcia? Yeah, I just wanted to make a comment on the techniques that are being utilized. What we're hearing is how we all really want to go to single session therapy and how we believe that's going to really improve costs and outcomes and reduce risks to the patient. And we did a single center performance improvement study on 150 patients that we had a single session, and we assumed that if they had an overnight lytic infusion in a step-down bed and also in the ICU, and what we found is we saved nearly $1.5 million in 150 patients by having single session therapy. So that's really what we're all trying to get as interventionalists. That's really sort of our holy grail. No TPA and single session therapy.
So that's roughly $10,000 a patient. That's good cost savings.
Good cost savings.
So what about the addition of ultrasound to the infusion of lytic agents, the echosonic catheter?
Right.
You've had experience with that?
Yeah, we've developed a technique going back probably now 10, 12 years. And first of all, this is really focusing on chronic DVT, the population that have already had their DVT, got post-thrombotic syndrome, are suffering quality of life limitations. And for a century, we've been telling them as physicians, there's nothing we can do about it. And these patients suffer tremendously. And what we found was that the use of the echo system allowed us to recanalize, if we can get across the occlusion, It allowed us to recanalize these chronically occluded venous segments and restore flow, and actually have nearly 90% patency rate on Doppler studies out 1 year, with a significant reduction statistically in our trial of both Villalta and VCSS scores, as well as quality of life. So there is absolute forward movement in our ability as interventionalists to help patients that suffer from post-thrombotic syndrome.
So even in chronic scarred, collagenous, occluded vessels, we can anticipate improvement if those procedures are performed properly.
Correct.
So what about the pure suction device? There's a device called the Penumbra, or made by Penumbra,
Indigo system.
the Indigo system catheter. That can remove fairly large volumes of thrombus in a session. Is that correct?
That's true. It's an effective system, and they have there's a mechanism and a short learning curve to the use of the device and efficacy. Now, we have found out that especially when there's no flow in the system, that the system works very well, and you can pull large volumes of clots out. I personally find the Indigo system very useful in trifurcation clot, when there is embolization or in situ thrombosis on the arterial side, tibial vessels, that it's highly effective and fairly quick. In the old days, we used to do thrombolysis in these patients, and on the arterial side, the risk of bleeding was higher than in DVT patients. So that has really been helpful in our practice.
Have any of you had experience with the Clottriever or the Clotriever catheter?
That's by Inari. Yeah, that's a clever system, and the idea is to it's an expanding net that you put on the top of the clot, and you encapsulate the clot and pull it into the funnel. It's very clever. It works well. Hopefully
Very acute clot.
acute clot, exactly right. It's acute clot or clot that is not adherent to the vessel wall or is not aged. It works well. To the extent that even aged clot can be removed and put in the middle of the vessel, it can be removed with this system.
So has the ATTRACT data, I should say have the ATTRACT data, that was published in the New England Journal back in December of last year, has that altered your approach to patients with acute deep venous thrombosis?
Actually not. We know that patients with iliofemoral DVT have a clear benefit for thrombus removal. Therefore, I think the statement is clear, and when you go to the subgroup analysis of ATTRACT, you find this proven. The subgroup analysis showed that iliofemoral DVT patient improved after clot removal. What is absolutely clear that femoral popliteal DVT shouldn't be treated with an endovascular approach. I think this is again proven. My personal opinion is that we should perform another study after ATTRACT, which includes all the existing recommendation we have so far of dedicated venous stents, not using arterial stents, and really focus just on iliofemoral DVT patients. And with that, I believe we can definitely move forward. But of course, we need more data. This is, I think, absolutely clear.
So just to add a little bit of granularity to what you said, Michael, the iliofemoral DVT data have been accepted. The paper has been accepted by circulation. It will be out very shortly. And it showed rather convincingly that there's a significant reduction in moderate post-thrombotic syndrome, significant reduction in severe post-thrombotic syndrome, a significant improvement in disease-specific quality of life, and significant reduction in pain and swelling in patients who were randomized to PCDDT compared to the controls. Didn't reach the primary endpoint of a Villalta score greater than 4, but there are many reasons for that. But for what matters to the patient, it was all positive. So this has been a great discussion. Any closing comments? Michael?
I think we are on a great success for preventing post-thrombotic syndrome with the modern technology we have. I think it's very important to set up adequate studies and try to bring up a kind of pathway to how to treat these patients with the already existing technology and data. And with that, I believe we can prevent a lot of post-thrombotics, especially in patients with ileocecal DVT.
Dr. Garcia? Yeah, I would agree. I think the real key for us is to identify those patients who are going to declare themselves towards developing post-thrombotic syndrome. And if anything, the ATTRACT trial really just solidified our algorithm of identifying that population, which is we don't treat early. And actually, we take we extend the acute definition out to 4 weeks because our experience has been that they are as successful in removing clot. So we allow our patients to get out to 4 weeks before we treat them, which gets them closer to declaring themselves. But the good news is that there's a lot of work, there's a lot of research, there's a lot of infusion of industry and government money into this DVT world, and the acute and chronic patients have a lot to look forward to in being able to be helped.
Dr. Razavi.
Longest time, as all of us are aware, the importance of venous disease and impact on the quality of life of patients has really not been up there on the awareness of the medical community in general. It's good to know and good to see that all the studies that are going on right now, all the R&D, all the developments have actually not only increased the awareness of venous disease among vascular specialists, but also among the general medical community, which can only help our patients.
Well, these are very pertinent comments. Gentlemen, I want to thank you for joining me this afternoon. It's been an invigorating discussion from experts who have a broad experience in managing extensive deep venous thrombosis. And this is, unfortunately, a field that continues to grow. More and more people are developing deep venous thrombosis on an annual basis, not only in the United States and Europe. So selecting those patients that will benefit substantially from clot removal is a very important target for us to pursue. Thank you very much.
Thank you. Thank you. Great.